Hello and welcome to Ethics for Ophthalmologists, a recording of a talk recently given to the West Australian branch of the Royal Australian and New Zealand College of Ophthalmologists in May 2021. My name is Ross Littlewood. I'm an ophthalmologist with a degree in philosophy and a special interest in ethics. It may have come to your attention that in modern discourse, it is not unusual to hear people attempting to defend a private ideological belief by accusing their opponents of having inferior ethical standards. This is an interesting argumentative ploy, since in the first case, it is an example of an ad hominem fallacy. In other words, it fails to address the issue of substantive difference. And secondly, it's a clear example of how the meaning of ethics can be misunderstood. For ethics, fundamentally, is a capacity to imagine yourself in the shoes of another and a willingness to take that perspective seriously, something that ideologues are not very good at. Ethics as a discrete discipline owes its origins to Aristotle, who used the word ethos to mean individual character, especially the degree to which a person demonstrates excellence of judgment. The etymology of ethics derives from ethikos, meaning customary habits, later translated by Cicero into Latin as moralis. But due to semantic drift, in modern English, the meanings of these two words have drifted apart a little, so that ethics usually means a normative statement about the expected standards for the non-coerced words and actions by a moral agent from a social perspective, whereas morality usually means the embodied consequences of a moral agent's behaviour on other moral agents or moral patients. However, the distinction is more a matter of emphasis than substance. Note that a moral patient is an entity that has no agency. Social psychologists, notably Jonathan Haidt in America, have recently gone a long way to explain our moral intuitions. One way that this can be understood is using the analogy of taste. All people share 5 taste receptors, but enculturation encourages those raised in a particular culture to develop shared flavour preferences common to that culture. The flavour of a dish depends on combinations of stimuli to 5 taste buds, which are universally present, plus perceptions in the mouth and nose, including those of heat and pain, which produce the experience of spiciness. The analogy with morality is that all people are thought to have 6 innate moral foundations, which are genetically determined. These are, as it were, ethical perceptual domains, and they arose as part of our evolutionary psychology. In addition to those moral foundations, we also absorb moral norms based on our social experience. Culturally defined groups develop certain moral intuitions that differ between cultures in a manner analogous to cultural cuisine. These intuitions are expressions of which of the moral foundations a particular culture values most highly, as well as which behaviours are expected. The 6 moral foundations are care versus harm, fairness versus cheating, loyalty versus betrayal, sanctity versus degradation, authority versus subversion, and liberty versus oppression. Sanctity is a more important norm in the Vedic culture than the Confucian, but respect for the authority of ancestors and leaders is a more important moral norm amongst those raised in a Confucian culture. American Republicans value personal liberty more than Democrats, and Democrats value empathy more than Republicans. The Aussie tradition of nature values loyalty and care more than other foundations. But regardless of which particular culturally defined set of moral intuitions a person holds, they're entitled to claim that their ethical beliefs are strong and appropriate. These ethnographic differences between individuals and between cultures are called descriptive relativism. Now, this is nothing but a statement of observed fact, and it is quite different from ethical relativism, which is a theory that claims that there are no objective truths in ethics. If a New Guinean headhunter thinks themselves just as ethical as a conscientious objector in a Western culture, how can there be such a thing as moral right or wrong? Well, to ask that question is to confuse descriptive relativism with ethical relativism. Ethical relativism claims that there are culturally specific moral norms and that each society requires its members to observe them for the good of that society. But what makes them right or wrong is a subjective opinion not an objective fact. It also claims that there are no views from nowhere, so therefore there is no culture that can judge another, nor can we judge our ancestors, since there is no such thing as moral progress. The third claim is that we should tolerate the moral codes of other cultures, since to judge them is to implicitly claim moral superiority. A practical example of the difficulty of achieving international consensus about ethical standards can be found on Facebook's oversight board that deliberates about whether posts that generate objections should be taken down. The 20 members of that board were chosen from diverse cultural and ethnic backgrounds, and despite each having relevant expertise, they sometimes have enormous difficulty agreeing about whether a particular case is acceptable. Another implication is that there can never be an ethical machine that could replace human ethical decisions, because much of what constitutes ethical decision-making is subjective and culturally contingent. Ethicists tend to approach their subject with more intellectual humility than the AI community. Applied ethics denotes a group of subspecialties, including medical ethics, professional ethics, business ethics, bioethics, and others. Like the word ethics, the word bioethics has undergone a significant semantic drift since it was first coined in a paper in 1974, in which it was argued that the survival of the total ecosystem depends on the value we place upon it. Bioethics has since come to mean ethical issues arising from the biomedical sciences. Medical ethics, which is our topic here, concerns itself with ethical issues arising from the practice of clinical medicine, and obviously there are particular differences in an intimate clinical setting that may not apply in other forms of applied ethics. It is not an independent body of thought and bespoke practices, but a hybrid combination of bioethics, professional ethics, business ethics, together with some uniquely clinical norms. All of these types of applied ethics were developed outside of academic philosophy, and they have the aim of providing a more efficient yield than the traditional academic approach of long and arcane discourse. Using sets of principles assists with ethical decision-making by non-experts, but there is no overarching theoretical justification for which particular principles are most appropriate for any given analysis, and that is the strongest criticism of principlism. Modern medical ethics uses the algorithmic framework of principlism, first formulated in 1979. It was designed to ensure each substantial ethical concern is explicitly addressed as part of an ethical judgment. The outcome is seldom as determinate as a medical diagnosis and has been described as a state of reflective equilibrium, which is a moment when all issues of known importance to the subject of inquiry have been acknowledged and considered. It is not an unassailable truth. The four original ethical principles were autonomy, justice, beneficence, and non-maleficence, but various subspecialties have since adopted additional principles. For example, in public health, the additional principles of health maximisation, efficiency, and proportionality have become standard. Research ethics also employs different principles. The NIH in America used the 7 principles listed on this slide. In Australia, the NIH and MRC employ the 4 principles listed, although they alter them slightly when dealing with people who are from Aboriginal and Torres Strait Islander backgrounds. Later in this talk, a worked example of an ophthalmic case study that uses the original 4 principles will be provided. The ethical frameworks developed over centuries within the Philosophical Academy are also used as part of modern medical ethical analysis. They can be broadly reduced to 3 types, the first of which is rule-based, including divine commands and Kant's improvement on the golden rule called deontology. For Kant, there is a logical imperative to follow only rules that we can wish would be universalized, and using this principle, he improves on the golden rule, since he avoids paradoxes like a masochist causing pain because it is how they would wish to be treated. Kant argued that autonomy is a moral obligation for humans with a capacity for rational free will. Other philosophers, notably some existentialists, have pointed out that the capacity of rationality that characterizes mankind condemns us to make autonomous choices. Although there is theoretically no hierarchy within the four principles, it has been argued that without a capacity for autonomy, the essence of what it is to be human is missing. And questioning whether a biological human is a person or not based on that capacity is very controversial, especially at the beginning and end of life. The ethical codes of RANZCO, Royal Australian College of Surgeons, the AMA and the Medical Board of Australia also rely on rules, albeit practical guides rather than absolute dictums. All rule-based ethical systems make a claim to moral authority, which can be questioned, and those that are prescriptive in the manner of a stop sign invariably produce inconsistencies, and these simply lead to more questions. Even "thou must not kill" has exceptions. Consider a terrorist about to detonate a nuclear device in a large city. On the other hand, those rule-based systems that are prescriptive in the manner of a give way sign tend to apply more universally, even though they require more interpretation. For that reason, the Good Medical Practice Code of the Medical Board of Australia is the best composed of those mentioned here. Utilitarianism, or consequentialism, is the second of the traditional philosophical ethical systems. It takes various forms, but it can be thought of as treating ethics as a form of moral accountancy. In the medical context, we encounter this paradigm in the use of QALYs, or quality-adjusted life years, and in public health policy more generally. A common mistake in ethics is to misapply utilitarian methodology when dealing with individual persons, since at an individual level, ethical reasoning should proceed from the particular to the general, whereas in social policy, particulars are excluded from consideration. An example of this error is the misuse of the famous trolley experiment, where a person is asked to decide if they would pull a lever to divert a runaway trolley or train that is racing along a culvert into a tunnel where there are 5 people who will be killed if nothing is done. The lever will divert the trolley to a side track which leads into a different tunnel where there is only 1 person who will be killed. In this thought experiment, there are no practical options other than to either pull the lever or refrain. But without the particulars, this ethical question is actually meaningless. If the 5 people on the track are terrorists on their way to commit a massacre at a local children's playground, and the 1 person on the side tunnel is a scientist about to reveal a cure for most types of cancer at a medical conference, the entire thought experiment changes. Utilitarianism must be used carefully when considering individuals and small groups. The third of the traditional paradigms is virtue ethics, which harks back to Aristotle's notion that self-regulation and a lifelong process of self-perfection are the essence of what it is to be distinctly human. A virtue ethicist might argue that rule following need not necessarily imply personal morality, and beneficent outcomes may occur accidentally, so the only certain way to judge a person's morality is by the intentions of the agent. A virtuous moral agent self-regulates so as to aim for the greatest good, and the practice of striving towards morally virtuous outcomes has the consequence of improving the agent's moral virtue, regardless of whether or not beneficent outcomes always result, and also regardless of how many different outcomes result from a particular action. From this perspective, being a good doctor requires first of all being a good person, and only secondly being a medical expert. A virtuous doctor is one who seeks to understand the options available and makes choices that avoid extremes, always aiming to achieve the best balance in a world where every action has multiple consequences. Consider the first ophthalmologist, who might approach each patient as an exercise in comprehensive care, investigating their psychology, social situation, medical history, and all the details of their examination comprehensively, and then laying out all the treatment options in a lengthy process culminating in a point-blank refusal to make any treatment recommendation on the basis that doing so would offend the principle of autonomy. Now consider the second ophthalmologist. This person might use every available piece of automated technology and as many assistants as possible to minimize the need to spend time with the patient, claiming that a well-equipped practice is the best way to analyze a patient's problems, and since that requires cash flow, the consultations must remain brief. This second ophthalmologist might also claim that social justice is best served by making only one specific treatment recommendation. and minimal explanation, since conversation in the face of clinical certainty is a self-indulgent imposition on the Medicare system. Now, Aristotle would argue that a virtuous ophthalmologist would understand the benefits and disadvantages of both approaches and aim to find the best balance for each patient. Virtue ethics is an approach that is well suited to judging the actions of individual moral agents and to the sort of self-reflection that leads to self-improvement. Medical ethics owes a great deal to the conceptual framework of professional ethics. There are three concepts that are especially relevant to medical ethics, one of which is the idea of privileges and obligations, that is, the relationship between the profession and broader society. Another is the obligation that professionals have to curate a boundary between their professional selves and their private lives, and try not to let those two blend into one another. And the third is the obligation to maintain professional independence in the face of commercial pressures. Many notables have criticised the medical profession for not living up to its obligations or taking more from society than it gives. For example, George Bernard Shaw said all professions are conspiracies against the laity in a play called The Doctor's Dilemma. The economist Tim Harford wrote a book called The Undercover Economist, which is full of scathing criticisms of the medical profession. And Milton Friedman, a Nobel Prize-winning economist, made a presentation to the Mayo Clinic in which he argued that the medical licensure should be abolished along with all government payments and regulations. That talk is available on YouTube under the title Curing American Healthcare. In 1989, the ACCC in Australia investigated the Royal Australian College of Surgeons for anti-competitive behaviour and concluded it restricted competition by making selection standards too high. That does sound a fairly controversial claim, because there may be those who would claim standards in professionalism may require high selection standards. Nevertheless, that was the conclusion. In 2004, the ACCC then went on to investigate the procedures of other colleges, and in 2005 issued a report in which it claimed that all the various colleges placed restrictive quotas on examinations and training positions and did not take sufficient account of overseas training. That report didn't seem to acknowledge the fact that much of the restrictions were economic and imposed by the local government-funded hospitals that restrict the number of training positions in each city. Nevertheless, the report was quite influential, and the Competition and Consumer Act has led to an increase in transparency by all the medical colleges and modified their selection practices. This slide summarises just the most important privileges and obligations. And the question is, how should we act to justify these entitlements if skeptics like the ACCC are watching us and various notables are critiquing the profession when certain members don't live up to their obligations? An important aspect of professional ethics is boundary crossings and violations. First, in regard to patients. This obligation presents unique challenges. A boundary crossing occurs when a professional performing their professional duties displays their private rather than their personal persona. Examples include spending extra time with the patient to discuss matters outside of patient care, sharing personal information with the patient, and entertaining the patient rather than attending to them. A boundary violation occurs when a patient is exploited by selling them products attempting to change their mind about politics or ideology, or a doctor treating her or himself or their family. In this scenario, there are both boundary crossings and violations, and if you read it, you will see that it's quite difficult early on in this scenario to see what is coming, but by the end it's clear that this professional person did not curate their boundaries successfully. Another boundary that is controversial is that between the professional and trade representatives, since this involves professional independence. Boundary crossings with reps occur when commercial bias undermines professional independence, and boundary violations occur when a rep gets between a doctor and a patient. In this scenario, a boundary crossing and a violation also occurs. Now, there are those who would push back against this claim that professionals should observe boundaries. However, it is not the case that doctors should not use the time in the consulting room to build rapport with the patient or to encourage the sort of trust which assists the therapeutic relationship. It is merely the case that any conversation outside of what is useful for the patient and aimed at enhancing the good of the doctor is illicit in the context of a professional consultation. Medical ethics also borrows heavily from business ethics and bioethics. From business ethics, it gets ideas around prudential practice management, fair dealing, bribery, discrimination, advertising, and fiduciary duties. There is no substantial distinction between a highly skilled and ethical entrepreneur and an equally skilled medical professional, other than the claim that the medical professional makes to place the interests of the patient above their own. If a medical professional in fact does not do that, then on what basis should they be entitled to receive their medical privileges? Those professional privileges include regulatory protection and the Medicare co-payment. Bioethics provides several elements to modern medical ethics, but most of all the approach called principlism, formulated in 1979 by Beauchamp and Childress. In their book, they proposed the original 4 principles, which were respect for autonomy, beneficence, non-maleficence, and justice. During the 1980s, Amartya Sen and Martha Nussbaum articulated their capabilities approach to human rights in an effort to answer the question, a right to what? And their work indirectly helped to popularise principlism, since which time various medical specialties have added further principles. So this is a case study of a patient, JM, who wants to continue driving as long as possible. We need to consider her autonomy, justice, beneficence, and non-maleficence. From the perspective of autonomy, she needs to be able to make informed choices. Surgery under topical anaesthesia would expose her to the least surgical risk, but other options include a short-term restricted license or relying on others for transport and avoiding cataract surgery, at least for the short term. The risks of surgery include the inevitable aggravation of her Sjögren's symptoms, and despite her penicillin allergy, she may need intracameral antibiotics and will need to be informed about that. There may be other parts of the informed consent process which are difficult for her to process. However, autonomy in such a case where there is so much at stake does require a very full conversation. Justice requires accepting her younger sister's offer to defer surgery so that JM can have her surgery sooner, provided the hospital will allow that to occur. Extending her license with conditions might expose other road users to a small risk, and so from that perspective, not operating on her cataract might be perceived as a form of injustice to society if she was allowed to continue driving. Beneficence requires a good surgical result from the cataract to maximise the benefit, and doing it sooner rather than later. Other opportunities to maximise the benefit include selecting her lens implant power to match her anticipated lifestyle requirements, which mainly involve indoor activities, and arranging for visiting nursing care post-operatively, since she may have trouble complying with drops and may need assistance since she has only one useful eye. Non-maleficence involves anticipating and mitigating side effects, especially the ocular irritation from her dry eye. Avoiding injectable anaesthesia due to her apixaban would reduce some potential risks. Since she has only one good eye, if the ophthalmologist she is attending is not a confident surgeon, then referring her to a more experienced colleague may be appropriate. What if non-maleficence is untrue? Medical and surgical complications are the third leading cause of death after heart disease and cancer. Surgical complications occur with or without an error of commission or omission. When a complication occurs in the absence of an identifiable error, the aggrieved subject deserves equal consideration to those harmed by error. In both cases, it is important to demonstrate that the harm is taken seriously and investigated appropriately with a view to a root cause analysis. Blame should be avoided in conversations with an aggrieved subject, but rather the conversations need to be constructive about what can be done to help the patient and improve the system. How should we proceed after inadvertently violating the principle of non-maleficence? In addition to following the 4 principles, there is a prima facie obligation for reparation that is the most minimal form, involves an apology. The physician may suffer emotional or professional harm and may become so anxious or depressed that they become professionally impaired. The physician's self-worth is less likely to be damaged if there is an opportunity to lessen the harm by supporting the patient's autonomy, which may involve obtaining a second opinion. Professional colleagues have a responsibility to provide collegial objectivity and empathy, but when serious errors occur that raise questions about a person's competence, then as a professional, they are obliged to report a dangerous colleague to the medical board. A collective responsibility syllogism is climate change will cause adverse health consequences. Physicians and physician groups have an ethical duty of non-maleficence. Therefore, physicians and physician groups have an ethical duty to minimise climate change. If this argument holds, and I believe it does, then over-reliance on disposables in the name of infection control adds unnecessary waste and cost. There are centres of excellence in overseas countries that have a very similar complication rate to within Australia, but use a lot less consumables. And it is likely that future change will be forced upon Australian medicine system because the amount of consumables we generate seems to be unsustainable. Our professional organisations should provide us with information about what surgical supplies involve the least waste and the least exploitation in third world countries, as well as an evidence base about the safety of alternative practices. And this, I believe, is a project that the Royal Australian and New Zealand College of Ophthalmologists is already taking seriously. In this cataract set, there are disposable items that may have been made from clear-felled forests, manufactured by exploited workers in a third world country, or produced in factories that polluted their local environment. It is very hard for us to know. The privilege of self-regulation carries a shared responsibility to discover all the consequences of our collective actions and minimise them. What if it was the case that we all agreed that the ideal operation would use one instrument and consist of one manoeuvre, and that everything we add to that needs to be justified by Kant's universality principle? In other words, we must wish that for every extra item we place on the trolley, it is legitimate that that should be there for every case performed by every surgeon universally in the world, and if not, we should think carefully about how we could decrease the wastage. Social media raises special challenges for professionals, yet it is promoted as a resource for enhancing reputations and driving referrals. Can professionals cultivate a social media presence for personal gain and still maintain boundaries? The dominant communicative paradigm in social media involves engagement across boundaries. It is very difficult to imagine how a professional could consistently focus on a patient's interests, maintain privacy and avoid misleading statements in a high volume and time-pressured discourse curated by a for-profit organisation. One response to that criticism is that doctors on social media do not enjoy all the privileges of professional life in that space, so they should not need to observe all their professional obligations in that space. But this amounts to an argument for dual standards, the virtual and the real. And that is not realistic, since there is no way to prevent a conversation that started on social media continuing inside the clinic. Another response is that there is an analogy with the rules of advertising. It is licit to make statements within the advertising world that are not literally true, provided those exposed are culturally competent enough to understand how to interpret them. Even if we accept that exceptionalism regarding literal truth is an established norm in advertising, that does not mean that there are not those in the community who do not expect the literal truth to apply as much in the virtual world as it does in the real world, especially when their interlocutor is a professional. In summary, ethical thinking takes non-clinical concerns seriously. It demands epistemic humility, since we are denied access to much of what matters to others. It's effortful, but the effort bolsters self-esteem, forges social solidarity, and enhances personal objective welfare more than any other pursuit. Thank you for your attention.